Hello, my name is Isabella Barone, and I decided to do my project on sertraline. So to start off with some background, sertraline is known commonly as Zoloft and Pfizer. The first antidepressant choices included tricyclic antidepressants and monoamine oxidase inhibitors. Selective serotonin reuptake inhibitors revolutionized the treatment of mood disorders and included drugs fluvoxamine, which was introduced to Europe in 1983, and fluoxetine used in the US in 1990. After 1990, sertraline, the fully synthetic naphthylamine derivative, became popular for treatment, showing efficacy against mood disorder symptoms with improved tolerability, decreased adverse effects, and relative safety in overdosage. So, sertraline is usually administered orally as a pill with an absolute bioavailability of over 44%. Its slow absorption creates a peak effect between 4 to 10 hours after administration. Taking sertraline with food has proven to increase its bioavailability by at least 28%, and therefore it is recommended to be taken with meals. About 98% of sertraline binds to plasma proteins. It also has high lipophilicity, making it available for extensive tissue distribution. Sertraline goes through first-pass metabolism in the liver by the CYP450 family. Research has shown at least 5 isoforms of CYP, 2B6, 2C9, 2C19, 2D6, and 3A4, play a role in metabolizing sertraline. But CYP2D6 is the most effective for clearance. The most prominent metabolite after first-pass oxidation is N-desmethylsertraline, which becomes more concentrated in plasma than the parent drug after repeated administration. First-order elimination has shown a half-life of between 22 to 36 hours, but usually about 26 hours. This means that once daily administration is usually only needed. People diagnosed with renal disease and hepatic impairment experienced a prolonged half-life of sertraline, and those with hepatic impairment also had increased plasma concentrations. While there is no difference in clearance based on the CYP2D6 metabolizers, people with poor CYP2C19 metabolite gene showed significant slower clearance. Furthermore, sertraline clearance was 40% lower in individuals over the age of 65. Moving on to pharmacodynamics. Serotonin, or 5-HT, acts as a neurotransmitter in the areas of the midbrain. A variety of psychological effects have been found to be mediated by at least 7 receptors for 5-HT. Actions on the 5-HT1A receptors in the brain limbic system are speculated to result in depression and anxiety. A depolarizing action potential at central synapses in neurons release 5-HT, which is then terminated by reuptake through the plasma membrane serotonin transporter, or SERT, a synaptic membrane amine transporter specific for 5-HT. Sertraline is a member of the selective serotonin reuptake inhibitor group, compounds that block SERT from exhibiting reuptake of 5-HT. Sertraline acts as an indirect agonist for serotonin receptors by binding to SERT. By blocking presynaptic reuptake of serotonin, sertraline increases the number of ligands available to bind to the postsynaptic neuron, decreasing symptoms of anxiety and depression. One of the ways that sertraline can exhibit its drug effects can be explained by the neuroplasticity theory of depression. Neuroplasticity refers to the brain's ability to be resilient, adapting as it needs in response to the ever-changing contingencies we face in our lives. The neuroplasticity theory of depression hypothesizes that pathological stress and major depression inhibit the brain's ability for this necessary adaptation, causing symptoms of major depressive disorder. It can also cause maladaptive plasticity, which may lead to psychiatric symptoms. The brain-derived neurotrophic factor, BDNF, is one of the most important factors that affects neuroplasticity. An increase in serotonin at receptor sites through SSRI application has been linked to an increase in the presence of BDNF, and therefore neuroplasticity. This results in an increase in resilience and a decrease in mood dysregulation. Sertraline has been proven effective in the treatment of depression in many double-blind placebo trials. It has shown similar efficacy to other antidepressant treatments with the advantage of minimal side effects, higher quality of life measures, and a quicker onset. Patients usually see a reduced presence of depressive symptoms after about 2 weeks of treatment, the starting dose being 50 milligrams a day, then increasing to 200 if needed. The efficacy of sertraline in the treatment of depression is believed to be related to the higher presence of serotonin in the CNS, specifically the pathway from the midbrain raft to the prefrontal cortex. Side effects of sertraline include sleep disturbance, increased anxiety, sexual dysfunction, and gastrointestinal distress. These are believed to be the product of sertraline binding to other serotonin receptors, 5-HT2 and 5-HT3, instead of 5-HT1. However, the side effect profile is still lower in sertraline than it is in other antidepressant drugs. So sertraline has been found to be a mild in vitro inhibitor of CYP2D6. However, this has limited effects on clearance due to the other CYP enzymes which help to clear the drug. The inhibition also dissipates within about 5 days of abstinence. Additionally, research has found that persistent use of sertraline can cause a downregulation of serotonin receptors and thus a decreased availability of serotonin. Withdrawal symptoms include dizziness, insomnia, fatigue, anxiety, agitation, nausea, headache, and sensory disturbances. These persist for about 3 weeks and can be decreased by slowly tapering off the medication instead of stopping it all at once. So sertraline belongs to the SSRI group of drugs, which are considered a safe class with little to no abuse potential. Compared to other SSRIs, sertraline's abuse potential is particularly low. However, recent literature has found that patients with a current or previous history of substance abuse have reported misuse of sertraline. These include taking them without medical reasons, such as reducing withdrawal or adverse symptoms of recreational psychotropics. For example, there have been reports of people on MDMA taking sertraline at clubs to prolong their high and making the come down easier. Given this, sertraline's high tissue binding makes it safe in overdosage. While symptoms can include soreness, nausea, vomiting, tachycardia, and dilated pupils, no patients have died when sertraline was the only sole ingestion taken. Thank you for listening. Have a great day.